Urostomy nurse at VA at the present time. Just want you to know about the Urostomy role. This is a specialty. I obtained my specialty at Emory University in Atlanta, and this is just to say that there are many opportunities for nurses. Specialties are abundant, and if you find something that you're passionate about, go ahead and pursue that, because it can be a good track for you, something that you can do always. Our role too is one of consultation. We are not per se the wound care nurses or the nurses that do every dressing on the unit. Nurses asked us what treatment can be used for specific wounds and so forth. So we like to do that as a consulting role. We like to be educators, so always wanting to share our knowledge with others. As far as the skincare protocols, any place that you go, there will be a risk assessment that you will use in your daily assessment. And the most common one that's used is the Braiding Scale. And I'm sure you all have seen that as you've done your work in some of the hospitals. Are you familiar with it? Yes. Okay. Yes. Well, the Braiding Scale basically, as you know, has the different things for the risk assessment. And those things are the sensory perception. And when you think of sensory perception, a lot of people think about your mentation. But we're talking about sensation to feel. Do you have sensation in your feet? Are you not unarousable? So think of that when you think of sensory perception. It's not only your mental attitude. It's if you can feel in your feet, body, or wherever. Moisture is the next one. If people are incontinent, of course that's going to break down their skin. So think of that. And a lot of times when people look at these, they think of subjective perceptions. And that's what it is what you think at that particular moment, what's going on with the patient. Next one is activity. Can they get up? Are they bedridden? Can they turn themselves? Do you have to, physically turn them? Nutrition. Do they eat well? Do you have to feed them? Kind of force them or encourage them to eat? And then the other one is friction and shear. And you think of that as people that when you roll the bed up, do they slide down? That is a big factor in shear. And friction also, if they have had some sort of surgery like a hip, and they are pushing themselves up with their foot, so that can cause a terrible blister on a heel. So you think of those particular things. Other questions about that? Alrighty. Now another time when we are looking at things that are on people's body, be concerned that when you're looking for pressure ulcers, you're looking for places that have a bony prominence. So only those areas are pressure points and can be called pressure ulcers. Things on anterior parts of legs, or surgical wounds, or people that have fallen down and lacerated themselves, you can't say those are pressure. So don't be confused about that, and do try to call things what they are. As far as staging wounds, that is not a hard thing. When you think about staging, you want to think about layers of skin. So stage 1, you have a reddened area and the skin is not blanchable. And when we say blanch, we mean that you push on the skin, and when you remove your finger, the blood circulation comes back to it. So if you push on the skin and it stays red, that is a non-blanchable area. So it is called a stage 1. Stage 1, the skin is not broken. It's just non-blanchable. For stage 2, of course that involves 2 layers of skin. postponed hazard. So the top layer of skin is removed. It's very superficial, and it's always red. So it's not any of that yellow or any of that nature in the wound bed. So it just involves 2 layers of skin. Stage 3, of course, dermis, epidermis, we're down to the subcutaneous tissue. And that's when you see the yellow, black, brown, and different colors in the wound bed. At this point, you can also have undermining, and that means that it's a lip on the wound. The wound has a crater, and you can place your finger right under the surface of the skin, and that's called undermining. Also in this particular stage, you can have tunnels. And of course, a tunnel is something that goes straight under, back, down, and you usually measure that with a cotton tip applicator or your finger.
Measure with what?
Cotton tip applicator.
Q-tip.
Q-tip.
It wouldn't be long.
And then stage 4, and that involves muscle and tendon. So you can see down to the bony surface. There are 2 more classifications that they have included now, and that is unstageable. And they included this because there was a lot of guesswork going on. People would see wounds with coverings over it, and they would guess that it was probably a stage 4. Who knew? So they put this in so that people can actually say it's not stageable because we cannot see the bottom of the wound. So anytime you have anything that you cannot see under the sludge or the debris that's in a wound bed, you call it unstageable. Then after you have cleaned up the wound, meaning you have treated it with some kind of debriding mechanism or it has been debrided by a surgeon, when you can see down in the wound, then you can stage it. And then usually that involves a 3 or 4 because it's really go down into the different layers of skin. Deep tissue injury is another category that has been added. And when you see purple discoloration of the skin, that's when you call it deep tissue injury. Sometimes it's harder to detect on darker complexion skins, but you can usually see a discoloration from the other surrounding skin, and it usually has a purple hue to it, even though the basic skin tone is darker. It's really important to document what you see because usually deep tissue injuries will break down into a more destructive layer of skin. So if you document it up front, when this happens, family members and different people cannot say, you caused this is something you all did, and really it was there from the beginning. Here again, your assessments are always important. When patients come in, admit it. Your documentation is the key, the first thing. If you don't document something is going on, then the hospital has to buy that injury, meaning the amount of money that's spent can be astronomical. And you have to think of that in the long term because if that happens all the time, then our pay is affected. So let's help ourselves. So here again, document what you see. If patients come in with dressings on, you have to remove them so you can document what you see. Because if you just say dressing dry and intact, what's under there? And if it's not described in the documentation, When someone does remove it and document that it's a stage 2 or 3, the hospital has to buy it. And when I say buy it, that means that insurance, government agents do not reimburse the hospital for that. The hospital has to take care of it. So that's a biggie. All righty. Any questions about staging? All right. I give you these picture documentations because the more you see it, you can kind of relate to what you see on a patient. Of course, everything's not going to be exactly as it looks on a picture, but you have some reference to go by to help you better document. Yes? They have a similar color, but tendons are more shiny if they are viable. Have a more shiny yellow, and sludge or non-viable tissue is like chicken fat. It's just kind of laying there with a real movable appearance. So that's one way to tell.
Sometimes you can see the tendons and they're just dried up, like a chicken tendon, like when you're eating a drumstick and you've got the tendon there and you let it dry out or whatever. It looks just like when it's having like a chicken bone. And we've had some patients where there was no perfusion at all, and that tendon's just dried up. I mean, that's really horrible to see.
It is. Another thing about tendons too, if it's still viable, when you move the extremity or whatever, the tendon will move. So you can see it moving down in the wound vac. Yes, ma'am.
If you have a deep tissue injury, do they normally remove that skin from the top and debride it?
No, ma'am.
No, they leave it alone?
Leave it alone. And here again, if you have a black eschar over a heel or somewhere, usually, it's mostly on the heel though, but usually people just paint that with a betadine to just toughen it up. And a lot of times these are on people that are not mobile anyway. So over time, that will just lift away. The edges will lift up. You just kind of clip off the edges, and when it's ready, it will lift away. And I say that about people that are not mobile. You're not trying to be aggressive because they're not going to get up and walk, so you've got time to just let it do its thing. Now, if it happens on somebody that is mobile, that is going to be viable, the doctors have a decision to make about whether to debride it, meaning to cut the dead tissue away and try to heal it. And a lot of times they do that. And they do it with different things, different dressings. And they can also use what is called a Wound Vac or a negative pressure device. And that's placed on to help the wound heal from the inside out. And this will speed up the healing. And people that are mobile can, be active quicker. But usually for an intact eschar, you leave it alone. Just paint it with betadine and let it be. Now the documentation of wounds is a standard thing. And when I say that, I mean that universally people understand the measurements of a wound. I gave you a centimeter ruler. And this is just a little trick that you can use or not use. You can measure your finger and look at the measurement of each digit. And if you don't always have this in your pocket or close by, you can use your finger to guesstimate the measurement. Just put it down and it looks like 4 centimeters. And then when you do your documentation, you say the measurement is approximate. Approximate measurement is, so that it's not an exact, but it is an approximate that can help you save time and get on out of the room. Not go look for this and come back and patients laying over and all those inconveniences. So do measure your finger, do measure each digit, and know what it is. This will help you in the long run. Alrighty. As I said, you will describe the wound. When you're looking at it, you want to describe its appearance, if it's red, if there's yellow in the wound bed. And don't try to use flowery terms, just say what it is. If it's yellow, non-viable tissue, the edges are red, just be descriptive of actual. You want to measure length first, up and down, north, south. That's your length. That's the first measurement that is written down. Your next measurement, of course, is east and west. That's the width. The next measurement is the depth. You can use the cotton tip applicator to stick down in the wound bed, or you can use your finger to come out, measure, or you know that this is 1 centimeter. So the depth is straight in. If there is undermining, you want to record that. Let's say we've got a wound and we've already done our measurements, our length and our width, and we have some undermining that is just like so under this edge. We would say undermining, whatever the measurement is, from 12 to 3 o'clock. So you use your clock face as your landmark. So the next nurse that's coming behind you can look down and know exactly what you're talking about. And never, never, never use terms like quarter size, 50-cent size. Everybody's got a measurement in their head about what that is, but it's not any distinct. So try to be more accurate with what you're doing and saying. Questions? Okie doke. There are other terms that describe types of drainage. Sanguineous is a thin, bright red drainage. Serosanguineous is a thin, watery, pale red, pink. And that's your second sheet of handout, so you don't have to write. Serous is a yellow, kind of clear, watery. Of course, purulent is pus, and that's a thick, cloudy looking output drainage. And of course, when we say foul, purulent, that means it has a smell. Now, over time, my smeller has gone out because I smell things all the time and they're not offensive to me. So what would be real bad to you is just like a smell. So if it's foul smelling, you can say like a pungent smell to it or whatever. Of course, I smell the scent, but it's not offensive is what I'm saying. And then the amounts. Here again, amounts are subjective. Small amount on a dressing, maybe about 2 centimeters in width. That's a small amount. And then as it gets larger and overtakes the dressing, it can be large amount of drainage. Anytime you have redness to the peri-wound skin, you want to make note of that, because sometimes that denotes some kind of infection in the wound bed. So if there's redness to the peri-wound skin, there is some kind of infection involved. And wounds that have been there a long time are what we call colonized. That means that there's always a germ in the wound bed. Not all the time do you have to give high-powered antibiotics. Sometimes they kind of resolve themselves with just treatment because the body will take care of itself. We'll fight off some of these germs without always getting antibiotics. Now, some of the dressings that are used for wound care the first one is a thin film, transparent. There are many names for them. There are many names for them, but this is a thin film, transparent dressing. Never put a transparent on a skin tear. And the reason you don't want to do that is because it will not absorb any drainage. And then when you pull this adhesive off, you're doing more damage to the underlying tissue. So transparents are usually used for holding down IVs or holding down a dressing, or you can use this to window frame a hydrocolloid. Hydrocolloids are like hydrocolloids are like duoderms, and I know all of you have seen hydrocolloids. Alrighty, there are many manufacturers. This is Tegasorb by 3M. Convatec has the brand name Duoderm. But the main purpose of a hydrocolloid is to absorb drainage. Now, if anyone has seen a hydrocolloid on a wound, you know over time it will kind of shrink, wrinkle, just kind of bundle up on itself. And this is what I was saying about the transparent. You can window frame, cut the strips, and put it on the sides of the hydrocolloid. Now, the Tegasorb, 3M got smart and put a transparent on the outside of its hydrocolloid to try to keep it in place. So, but if it doesn't have a barrier on the outside, that's what the transparent can do. Hydrocolloids are left on from 3 to 7 days, depending on the drainage and the size of the wound. The next category of dressings are foams. There are a lot of foams out there. They're real convenient to the nurse. Polymem is a foam that is used at Rowan and the VA. It has a cleansing agent in it, or a surfactant that will help to clean up the wound bed. Always put the clear side down to the wound and the writing away, and it just wicks the drainage into it. Depends on what kind of wound you would put it on. You can use it for skin tears because it does not stick to the wound bed, so that it comes off without causing trauma to the patient. It also does not have any adhesive to it, so you have to secure it with something. And paper tape or a cling would hold it down. Mepilex is one of the newer ones that have come out, and it has what they call soft technology. And when we say that, it's a silicone border around it. We just send this one around so you can just get a feel of it. This one can be put down, pulled up for 25 times. So the reason it's a good dressing, doctors want to see the wound. So you've just gone in, done your dressing change for the day, and they come in and take it off because they want to see it. Who gets mad? So with this particular dressing, they can peel it up, look at it, and put it back down. So here's a little education for the physician, but they know that they can peek and it doesn't disturb the dressing. Mepalex. Here you go, Carol. Carol. It's a real good dressing. Now there are other ones by different manufacturers. This one's a leave-in by Smith & Nephew. It's a foam, kind of a thick, spongy foam. So if you've got a patient that needs a little bit of pressure relief on their heel or some area, you can put something nice and thick, spongy on that area, so it will have just a little bit of relief to it. A leave-in. So the purpose of any foam, as I say, is just to wick the drainage away. It is a good thing for a lengthy dressing. It can stay on 3 to 7 days also. So it prevents you from going back every day and doing a dressing change. Absorbent dressings. Those are things like Aquasil or Sorbasan. And these dressings are made from seaweed. And what they do, I was looking for a trash can. What they do when they are moistened by the drainage in a wound bed, they turn into a gel. So, thank you so much. So, you put it in the wound bed dry. It absorbs the drainage so that when you take the product out, it doesn't stick, it doesn't traumatize the wound bed, it just easily wipes out. So the purpose is to keep the wound bed moist.
What's that called?
Aquasil. H-U-A-C-E-L. That's correct. Now when I say that wound beds are to stay moist, I know all of you have heard older folks say, give it some air. Let it breathe. There are no lungs in wounds. So remember, wounds need to stay moist. And when you think of wounds, when you look down into the wound bed, think of little tadpoles. Now you know how tadpoles go to the center quickly and shoot back out to the edges? That's exactly what cells do if they're kept moist. They come to the center and go back to the edges. And if you've ever seen a healing wound, you'll see the pinkness around the edge. That's the healing that has been caused by the moist cells that go back to the edges. So always keep a wound bed moist. If you don't remember anything else, remember that. And you'll notice there's a lot of ointments, like Neosporin. That's their only purpose, to keep that wound bed moist. It's not the antibiotic in it because it's really a small amount that really doesn't affect anything. It's just keeping that wound bed moist so that it can heal quickly. Now in children, they will heal in 3 days. On older people it takes a little longer because the skin, of course, has become older and our cells are not as happy as they used to be. All right. Let's see, can I grab another one? Got me backing up. Now, you know, a lot of surgeons like saline wet to dry. As we know, that is a painful dressing. It has its purpose. Now, if the wound bed is real dirty and they want to clean it up, of course, that's going to pick up debris and pull it away. I have not seen a nurse yet that would snatch it out without moistening it. We just can't do it. We don't want to hurt a person, so we saturate it back down with saline, which defeats the purpose, and then we gently take it out. So, here again, if we can talk a surgeon into moistening the gauze, yeah, but also using a gel that would keep that wound bed moist and cause autolytic debridement of the non-viable tissue that's in the wound bed. And when I say autolytic, I mean that this will break down naturally by the body and what we put into the wound over time. It would just soften up and we can easily wipe it out. So, gel is the next one. If they are adamant that they want to use saline and gauze, you say, okay, but can we put a little gel on it? Please? So how you talk to them. But then you can put a little gel on that moistened gauze and place that into the wound bed. And this is a daily dressing change, and it will help that wound bed to clean out.
So it just comes like a tube.
Comes in a tube,
What is it called? What is that?
This one is Safe Gel.
Safe gel.
And there are a lot of different kinds.
I just noticed in our fundamentals book as newer editions that we always had the, wet to dry is what they did call it when they went to wet to damp or wet to moist. And they don't have that skill in your wound chapter. It's not there. And it's because that's just an archaic way to do it.
It is.
Pretty much.
Right.
And you still do see it.
You still do see it.
Teach you how to do it.
That's correct.
Realize that's not our favorite thing, and certainly not Amanda's.
No, it's not. But if you do have to do a wet to dry or wet to moist, the right way to do it is to take your gauze out, and of course it comes folded like so. And never put it down like that. You have to open it all the way out. And then you fluff it. And then you saturate it with your saline. Make sure it's not too wet, so if it's too moist, do it out. And then just, fluff it into your wound bed. If there's undermining, you would put it underneath and then fluff the rest on top. So that's the correct way to do saline wet to dry.
You see patients coming back from surgery sometimes where the surgeon actually attached the whole 4x4 in there,
Just-
not unfolded whatsoever, and then they order to do the wet to dry the dressing. But it's like that is not the proper procedure. If you're looking at what the doctor did, don't say, oh, the doctor would do it like this, so that's the way he wants it done. No. That's not the way it works.
So then after, no.
Unless they say that is what they do.
Exactly.
So after you have it placed in, you want to put a cover on it. So that's usually an ABD, and then tape it down. Okay. And these are changed from every 8 to every 12 to every day. It just depends on what they say. The longer it stays in, the more it's going to stick to the wound bed. So it's usually more beneficial to do every 8. But here again, when you're using this kind of dressing, you're wasting nurses' time. You could put something in that will stay longer, and you won't have to go back as frequent. And then too, when you're disturbing a wound bed, you're changing the temperature of the wound bed, so that delays healing also. So if we leave it alone, Let the body do what it's going to do. It will do better. Yes, ma'am.
So on some of those that you said the dressing stays on for 3 to 7 days, you wouldn't take it off every day to assess it, or you would not?
No.
You would just note that it's there, that it looks good.
It's dry and intact. Not due for dressing change till da-da-da. All right.
You have the ventilator, the one that you can do up and down, but you got ventilators, you can look at it.
You can look, but it's no reason to peek.
It's not, if the doctor wants to,
They can, right, but we don't have to peek at it.
There was actually, I think it, I've read in, there's 3 different textbooks, the Gibbons and the Ileal and the Koger and everything, but in one of them it has a study about the economics of using these dressings, and that's always been the argument that it's so much cheaper to use gauze and saline. It's cheaper. Well, you send somebody home on home health, and they've got to have somebody change it every 8 hours or whatever, and you think about all the labor and the labor cost is tremendously more than if you put those 3 to 7 day dressings on.
Correct.
And it really is cost effective. Now, people are ripping them off and throwing them away every 8 hours, and they're not doing it appropriately. Of course, it is going to be much more expensive, but it is in one of those readings, I cannot remember which, but just look, it's in one of those boxes for evidence-based practice, and so look at that, and it really, this is the first time that's shown up in a textbook. We've switched some textbooks to new editions, and it's like, wow, this is,
And that's
they're
correct.
coming around for, it is standard practice now to go with those more expensive dressings and leave them on longer now.
And two, like your textbooks are coming out, it is evidence-based that the longer you leave dressings on, it's more effective. And then two, a lot of people look at the upfront cost of dressings, and of course, the foams do cost about $10 for one. So when administrators are looking at that, they're going, But if you look at, as Carol said, the cost of a nurse going to change that every 8 hours and the labor intensive of it, it really weighs out. So actually heals.
That's evidence-based too.
That's
isn't
correct.
Now,
It is.
That's really the crux of the matter, is that we're going to get the healing and less handling of things, less introduction of
Infections, right.
It really makes sense, just like having a closed system for a Foley catheter,
Right.
not opening it up and opening it up. You want to keep it closed so that the body will take care of itself, and that's really what those gels are about.
That's right.
Your own enzymes can go in there and debride it. If y'all hadn't done that reading about how that works, but that's one of those like chemical ways of debriding where you can actually introduce enzymes to debride, can't you? But and some dressings have some, don't they? Then your body can maintain some of those natural enzymes in some of those dressings too, and then actually clean itself up. So
Correct.
I think that's just very, very cool. That's what you're saying. That the body wants to take care of itself, but it does all it can to take care of itself, and we want to promote that rather than tearing it down by opening it up to cold temperatures and cool saline and all that kind of thing. So it really makes a lot of sense.
All right. And I just briefly mentioned the Wound Vac, and I know many of you have seen that, and that is a newer thing, not new, but it's being used more frequently than in the past. It's really been out about 20 years. It was developed at Baptist Hospital in Winston-Salem, and then KCI bought the brand and manufactured it from there. But they are now about 10 negative pressure devices, different kinds, different models, different sizes. The initial one was a larger one that held up to 500 cc's of fluid being drained off. Then it was developed down to a Freedom, or a portable one, that held about 100 cc's. Then from that, it was developed into a disposable one that they are using for cardiac surgeries and closed system surgeries so that it would stay in place for 7 days and then be taken off and thrown away. They are also looking at using it for knees and hips because they can just stay in place as an incisional vac and after 7 days come off. Another study is for the C-sections. Leaving it on for 7 days and those C-sections won't dehisce like they have in the past. Because mamas are not going to not pick up their baby. So a lot of C-sections were dehiscing. But if they had that negative pressure on, it would stay intact, give them time to heal, and then come off. So a lot of things are advancing in the wound arena if people would just go ahead and use them. Of course, the cost is there, but the long-term results outweigh the initial costs.
We were just discussing dehiscence and evisceration and all yesterday, all those great gross pictures we looked at. But for like C-sections, you talk about is it evidence-based that the wound vacs being used that way decrease the incidence of dehiscence in C-sections?
Correct.
Because Ms. Ward had a dehiscence. I meant to tell y'all that yesterday when she had her C-section and it started coming loose on the edges, some stitches. It was just a little bit of that, but then they saw that it was infected, and the doctor opened it up all the way, and they had to do the packing and all that stuff. So of course now that it would be a whole different situation. But that must have been pretty common then for C-sections too. Dehisce when people get up and move more than they maybe should.
That's correct.
And so that just makes perfect sense too.
Yes, sir.
Talking about different surgeries, I know that they have, the staples, the sutures, and then the glue. What about, have they started actually doing two types of closure, like sutures and glue, to make sure that the wound stays closed?
I haven't seen the two types. I've seen the glue, and those are really nice because you don't have a open area there. But I haven't seen them using both kinds.
And they have the sutures like in the lower, the deeper layers, and then the top layer has.
Yeah, I'm sure they have underneath sutures. I was talking about on top, staples and the glue. And all that surgeon's preference too. But it's good for surgeons to move on to newer things like the glue instead of all staple in.
In our nursing home, one of our nurses that came from Georgia, she had stated that when her patients would come in, they would put that sure prep on their heels to help keep from getting the ulcers and stuff on their feet. Have you ever heard of anything like that? Like pre-prepping the feet so that they don't get them?
You can pre-prep them to make them tougher, but you still have to turn them to relieve the pressure. You have to relieve the initial cause, but that just makes the skin tougher. Alrighty. This is saline that's used at Rowan. They use it in the can. As you know, if you open a bottle of saline, you have to discard it after 24 hours. So here again, this was a cost-effective measure because the can can stay until it's used up because it's a closed system. So that was one of the things. At the VA, they have the little bullets that respiratory therapy uses. It's 15 cc little bullet. That is just a one-time application. You just twist it open and use it. So different methods, but always think of what's cost-effective. For anyone that has been to Rowan, this is a barrier cream or barrier spray. And the reason they went to this was because when people have sensitive skin, they become chaffed or excoriated. They don't want anybody rubbing over that area. So the spray was just to spray onto the area, just no touch. It covers the area and stays in place. That way, if you ever notice too, when you're putting on barrier creams, you're getting it all on your gloved finger, and then you're putting it back onto the tube. You know, you can't be, so you're cross-contaminating stuff. So with this was a, less contaminated method. So there are a lot of barrier creams out there. You just want something that will protect the skin from the urine and stool that's coming out. I don't have a sample here, but the bed baths and the incontinent wipes, several hospitals use that. If you're using a bed bath, just use it for bed-bound people. People that can get up, walk around, please don't give them a bed bath. They can wash themselves, and you're wasting resources too. And I've heard people say they'd rather have a basin bath, but the reason they went to bed baths was to decrease decontamination. Because, when you're using a basin, and you rinse it out, you don't get all the junk out. Little bugs still stay there. So then the next time you're wiping it back on them. So that was one of the reasons they were trying to go to that. Incontinent wipes have dimethicone in the wipes, and that is just a barrier to keep the stool from sticking. It just slides off a little better so that it won't cause irritation. Okay. Yes, ma'am.
On the saline and the gels and everything, do people ever have allergic reactions to those things?
I've not seen anything. Most of those things are really tested, to make sure. But everybody's different. So if you do see any kind of irritation, just discontinue use. Yes, ma'am.
Hey, you had used the term AVD. What does that mean?
That is a absorbent barrier dressing. It's just a thick cloth absorbent dressing.
They put it on the abdomen a lot, and I think that's why they called it ABD. I think it just got named because it's abdominal dressings primarily, but not exclusively.
No, it could be on hips and heels and everywhere. It's just an absorbent dressing. I can't think of anything else. Carol, you know of anything? There's one thing.
I know you mentioned about doing the like Q-tips or the cotton applicators is the real name of it, like we say Kleenex for tissues, but did you explain exactly how, you said to do about like with the finger and everything, but if you're doing like measuring the tunneling and all that, I know you sort of mentioned it, but I'm not sure if we got that enforced enough.
Cotton tip applicators come like so. On some of them there is a measuring guide on it. So it's usually 2 in each pack. And this is how I was saying you would use this to measure your undermining or your depth. And you would use your Q-tip to go under and put your finger where it stopped, bring it out, quit it. And then use your measuring guide to measure how much that is. And as I was saying, you could use your finger to getting an approximate, but if you want an accurate, you would use this. For depth, you would go straight down, pull out, put your finger where the depth stopped, and then pull it out and measure. So that is just the simple principle of a cotton tip applicator. If you want to pack something, you also could use a cotton tip applicator. And when I'm packing, I use the wooden side, because if you use the cotton side, when you go in and pull back out, the gauze comes back. So lightly pack in with the wooden side. When you're packing, never overpack. Don't stuff it in. It's just a lightly fluffed packing, because if you pack too hard, you cause a pressure ulcer, and you don't want to do that. All right. What I went over to get this for, the principles of wound care, and we'll just lightly mention those. Anytime you have a wound, these are the principles that you want to go by. You want to first remove necrotic tissue. So you always are looking at cleaning up the wound. Promote moist wound healing. We discussed that, but that's the second principle. That was moist wound healing. Third, you want to identify and eliminate infection. Identify and eliminate infection. And at that point, you're calling on your doctor friends to help you do that. You want to absorb any excess, extradate, or drainage. And of course, you do that by your dressings, your Aquasil or your gauze or whatever. So that is absorb excess, drainage, or extradate. Obliterate dead space. And that only means that anytime you have a wound cavity, you have to fill it with something. Because if you don't, you cause an abscess. Because sometimes it heals over top, and then there's an abscess in there that they have to go back and IND or open up to drain. So anytime you have a wound, you have to fill the dead space with packing. Insulate the wound, and of course that's with your dressings. And we were talking about how you don't want to always open up because you're changing the temperature in the wound bed. So you want to always insulate that wound so that the temperature can stay the same. And then of course you want to protect the wound from trauma. And you do that by your dressings. And those are the principles of wound care. All right. Carol, we have gotten down to the 9:30 range. You want to break it?
Yeah, let's do it.
Of course, you know, any ostomy is done because of cancer. And they remove and fix up. But for a colostomy, that's usually located on the left side of the abdomen. The output from a colostomy is usually more solid and firm. For the right side of the abdomen, that is the ileostomy. And that output is usually more liquid and caustic to the skin. The next one is the urostomy, and that involves cancer of the bladder. Bladder's removed, and they perform what is called a Ileal Conduit. Ileal Conduit is made by removing a piece of intestines. And let's see, you have your, yeah. You have your kidneys and your ureters and the bladder, and then the bladder is removed. What's doing that?
Some tips on how to adjust that.
Okay, the bladder's removed. They take that piece of intestines. They take that piece of intestines and sew up one end. These are placed in that intestine. And this side comes out to the abdomen, which forms the stoma, and this is where the urine comes out. We understand? Okay. So now when that is formed, of course there's no sphincter. Urine freely flows out. Initially, when it's first done, there are stents that are placed in the ostomy, and you'll see the little plastic tubes coming out. The tubes come from here to keep this from blocking off and then come out. Over time, the tubes just work themselves out and the surgeon just clips a little bit more off. And usually within 4 weeks, all of the tube has come out, and sometimes the patient sees it in the bag and then they can throw it away. So if you have the opportunity to educate a patient, make sure you tell them that the tubes are working their way out, and if they see them in the bag, don't be alarmed. That's what's supposed to happen. Anytime you have a urostomy and you're pouching that urostomy, do not use any prep to the skin. Urostomy wafers are designed to be very durable, and if you use a adhesive agent, you counteract so it doesn't stick good. So do not use a prep to the skin, just the wafer. Now when you place the wafer on, of course you should do your change early morning or late in the evening, because as I say, urine is flowing freely and you've got to have a dry surface. So urine flow is decreased early morning or late afternoon. So that's when you should do your change. Now if you have an accident, or the patient has an accident and they have to change in the middle of the day, just try to be quick, because you've got to dry off, cut, measure cut, and place on. So if any urine gets on the skin before you are ready, you got to dry it off, dry it, and then place. So it is a work of speed. So as I was saying, you don't put any preps to it. When the urine flows out over time, say like on the 3rd day, the wafer will do what is called turtlenecking. And that means that it will hug up against the stoma. Just kind of turtlenecks. And you will see that, and that's a normal occurrence. So don't be alarmed of that. That's the way the wafer is supposed to do. It's trying to hug so that the urine will go over and not get on the skin. Alrighty. Urine, or the urostomy pouch, has a spout on the bottom. I wish I had brought one, but I don't think I did. And it's just a turn. If you don't see a little dot, on Comatec it's red, on Hollister it's gold. If you don't see the dot, it's closed. When you turn the little lever and you see the dot, it's open. So that tells you that the urine can flow. In the hospital, they usually connect them up to a bedside drainage, so the little spouts are always open and it's draining into a bedside drainage container. As patients get better, of course, this is disconnected so that they can walk around. Patients at home do connect to the bedside drainage so that they can sleep all night and not have to get up every 4 hours and empty their bag. Usually the bedside drainage bag is placed over a trash can. The bag is in the trash can connected so that, have somewhere to hook to. Our beds at home don't have little hooks like the hospital beds do. So they use that as their connection. Some people are fine with that, don't get tangled up, don't get disconnected. Some people have a little time with getting all tangled up. If that's a problem, just use some paper tape to secure it to their leg. Tell them to do that at home so that it will kind of stay where it's put so it won't become disconnected. Those are the most important things about a urostomy. Now, as far as the ileostomy, as I said, the output from that is real caustic. And if there's any accidents or drainage on the skin, spills, they feel like it's itching, change the whole thing. Do not try to tape down ostomy wafers. I've seen that, and that is the worst thing anybody can do. Take the time, take it off, and place another one on. Because if you get irritation to the skin, you have just caused yourself more time and effort by trying to treat that. So be preventive. Anytime a patient says, kind of itch right there, or ooh, I feel like it's running down my abdomen, go ahead and investigate, take it off, change. All right. As far as colostomies, patients usually don't have a lot of accidents with that because I said the stool is very formed, comes out, no problem. They can usually wear their appliance 7 days and go about their business. In the hospital, when patients have a colostomy, usually the rectum is sewn up. So patients feel like they're sitting on an egg. And they'll tell you that. It feels like, because that's where the surgeon has taken out the rectum and sewed it up. Be real meticulous with skincare, putting a barrier cream down there because they will have some drainage. The other thing is patients that have ileostomies, sometimes of course the rectum is left open. They had what is called a Hartman's procedure or whatever. A little bit of the intestines is still dangling there in the abdomen. So the inner lining of the intestines is kind of mucousy. So patients will have a sensation of having to go to the bathroom. So if they tell you, I feel like I got to have a bowel movement, don't think they're crazy. They still have that sensation, and sometimes mucus will come out into the commode. Tell them that's normal. Because sometimes if you see stuff like that, you're thinking, what in the world? So that's a normal occurrence to have the sensation of having a bowel movement. That will go away over time, but we're talking about immediately post-op. Alrighty. Now as far as changing out an ostomy appliance, initially, this is for the change of the whole appliance. You pick up the edge of the wafer, press down on the skin, and do that all the way around. That way you are releasing the adhesive gently without snatching or tearing the skin. All the way around, remove that appliance and pouch. You want to wash the skin with just warm water. No soapy, just warm water. And the reason you're doing that is because the wafer has protected the skin. It's not dirty. And if you use soapy water over time, you cause a soap film, and then the adhesive won't stick. So just warm water, wipe off. The stoma itself, that's the inside of the intestine, so there's not a lot of sensation. So you can touch the stoma, and the patient doesn't go, ouch. They don't really have a lot of sensation to the stoma itself. Now, around it, where the sutures are, of course they feel that. And as you know, the intestines were brought back and cuffed and sutured so that they could form that nice, pretty bud. All surgeons are not as talented to make pretty budded stomas. So we have all kinds. We have ovals, we have flush, we have droops, we have pretty. So you have all kinds of stomas. And it's our responsibility to measure it appropriately so that we can cut the wafer and have a good fit so that stew doesn't get on the skin. In all boxes of wafers, there is a measuring tool, and you would use that to measure your stoma. You would find the one that fits the best, and that one does it good. You want to have just a little leeway around the edge so it's not too snug onto the stoma. After you find your appropriateness, you want to take your wafer, and if you all would listen right now, and then you can do your work. You want to place it on the back of the wafer. Some have measuring indicators, and some are just plain. You would take your pen or magic marker, Sharpie, trace it out. After you've traced it, as you see, these are one-piece appliances. Some of you have two-piece appliances. So if you have a one-piece, just pull it away from the wafer. You would find the line that you have traced, and you have the curved scissors so that you can cut a circle. And you want to just, all the way to the end of the scissors, cut and turn.
Are y'all listening? Watching, and she'll repeat this again when you're actually doing it, but just listen right now and watch what she's doing.
After you have cut, if you have any jagged edges, you want to take your finger, smooth it out. And this is like a Duoderm. The wafer is like a Duoderm, so it's real palatable. So finger, smooth it out. Before you take your paper off, you want to just look, see if your hole is appropriate. And we have a good measurement. If it's too tight, then you can open it up with a little more cutting. But you always want to cut small and then go larger. Take your paper off. And with one pieces, I always fold it in half so that I can see the bottom edge. Place it on. And then it goes over and smooth out. There is a tape edge on that you tape off. And there's the edge. And I always turn it upside down so that it will just lay down flat as I'm pulling it off, like so. Then we have the tail end. And anytime you're putting a clamp on the tail end, you want to just Fold one time and clamp. Always check the security by just pulling on it. And never do this to a clamp. Roll, 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 roll. And the reason you don't want to do that is because over time you will stretch the mechanism. So the next nurse that's coming behind you is going to do it right, and she'll put one fold, and when she pulls, it'll just slide off. So one fold only, and it will be secure. Now when you're emptying, I always cuff it back. And meaning, cuff back. Can you see? Okay. Cuff back. And then empty out. You can teach patients to sit on the commode and empty between their legs, or empty into a measuring hat. I don't like to use urinals because the opening is so small they can't always get it in there. So one of the measuring hats, I think most institutions have those. After you do that, baby wipe, moisten paper towel, a toilet tissue, anything that will clean off the outer edge, and then bring it back down and make sure it's clean, because if there's any odor, it will come from the tail end. So make sure that's secure. Some of you have Velcro tail ends, so you won't have a clamp. This is a Convatec brand, and most of them fold 3 times, and I don't know today. And then just press, and it is Velcro. And this particular one has a cover over it that covers over and Velcros for the security. When it's open, of course, you just open the Velcro, come out with it, and it has kind of stiff sides that you just press, and it opens like so. Empty out. And here again, you got to make sure that it's cleaned out before you seal it. Okay. Questions about the procedure? Yes, ma'am.
If you have the oval stoma
Mm-hmm.
and you put the the circular around, how do you make sure it's accurate when you try to trace it on this?
Great question. When you remove if you have a wafer that's in a sealed up, you want to use you can use there it is. Place this over your stoma and use your magic marker to trace the size of the stoma and cut it out, and this is your template to go onto your wafer to cut out, trace and cut out. The other way is a little longer, but can be done. With your measuring tool, you want to measure the up and down. So you put it over and see what the size is for up and down. Then on the back of your wafer, let's say this is your wafer. That's a little hole in the middle. You have measured your stoma, and let's say that your size is this. You just want to mark at the top and mark at the bottom. Then you want to get your size of the width. And let's say the width is here. Make a dot here and here. And then you're connecting the dots. cut out, small, then open up until you have your good fit. So this one takes a little longer, but if you didn't have your see-through to make your template, that would be the way you would go. So I threw those stomas in just to indicate that everything is not pretty round. And we do have oval stomas and different sizes. Okay, let's say that you've got a stoma and the stoma is just beside a crease. And every time you put your wafer on, 6 hours later it's leaking out of that crease. So how would we correct that? All right. Say again?
Pull the skin tight.
You can do that. You can do that. But you're still going to have a little bit of a crevice that's going to cause a problem. So the way you would handle that, let's see where it is. This is called Stomaheesic paste, and it is a deceiving name because it really isn't a paste, it's a caulking.
Put it around your bathtub, you know, talk around the bathtub or around the imbeciles. For the stoma, there it is, just wafer.
And let's pretend this is the wafer. You would take the paste and just go around the opening that you have cut out. And of course the wafer is going to be a little more thick so that it will. But it's just like toothpaste, and you just want to put it around the edge. And then when you put it down over your stoma onto the skin, it will cork into that crevice so that the stool won't go down that little valley. So this is one way. Some institutions have what is called a Eakins ring or a adapt ring, which is made out of the this kind of stuff. And here again, I wish I brought one. But it just pulls out and over the stoma, and it's real palatable, and you just fill it in to the little dips and levies, and that will stop the stool from going into the area also. So there are things out there to use to keep the patient from leaking all the time. And it does get frustrating for patients. If they're leaking, then they feel like they can't go anywhere. They have to stay at home. They can't socialize. They don't want anybody to come over because they might smell. So it's a lot of issues with leaks. So we want to correct those as soon as we can. And if you're in an area that has a wound care ostomy nurse and you can't find the solution, refer them out to the person so that they can have some peace of mind. Okay. All righty. Any questions? Yes, sir.
How would you obtain a urine sample from that, or like a clean temperature or a sterile urine sample?
The only time you should use the urine out of the bag is if you had just put it on. It's a clean bag, but say like the bag's been on 3 days and the physician wants to clean. You have to take it off, clean it just like you were doing a clean catch. Clean it real good, and then hold the cup and wait. Get your clean catch there. They don't recommend putting catheters in because you can traumatize something. So if you in a hurry and can't wait, you have to take it off, clean off. You can put a clean appliance on, get the urine in the bag, and then use that. But never take urine out of a bag that's been on longer than 8 hours, because you're getting contaminants all in there. Alrighty, we're gonna play. So, take all of your things out and